art section. The topic is pediatric living donor liver transplantation, and we are privileged to have Professor Mohamed Rela to talk on this topic.
Well, thank you very much, everybody, and it's a great pleasure to have everybody here. And it's a great pleasure to have Mohamed Rela, who's really known to all of us. Briefly, Mohamed is, or used to be, a professor of surgery at Guy's Hospital before he moved back to Chinoy. And I'm not sure if anybody has an institute named after him, but he has the Rela Institute in India, where they perform about 250 transplants. He's an incredible surgeon, has had a lot of publications and a lot of thought into how things are done. And most of all, he's a great friend. So thank you very much for being here, Mohamed.
Thank you, Mark. I think I need to thank the organizers. Yaman's been a great friend, and Dennis, it's been great, actually. The crowd is, I think of all the meetings I've been to, I think this crowd is probably the most learned crowd in liver transplantation. I'm pleased to see many people. I'll mention some of their names. And I've also realized that we have a unique ability to watch something else and listen to something else. And I used to think whether people focus on the talk. I do believe people focus on the talk, because I've been able to watch that and focus on the talk. And I've realized that our sensory eye ability is better than listening. We won't be able to do two people talking and one picture. Here we are actually looking at two pictures and one person talking. That is something I've realized about the human beings. Maybe you're all very highly specialized human beings sitting in this room. This is a great subject of mine. I've been in King's College Hospital, Mark, not Guy's. Guys don't do liver transplantation. So Paolo's here. So the first ever liver transplant, which was attempted by Thomas Starzl, happens to be a pediatric liver transplant. I'd like to tell people that pediatric liver transplantation has been ahead of adult liver transplant by at least 10 years, and I'm going to show you why. This is Professor Ott. You've got Jan Leroux here. I think pediatric liver transplant, I think, is pushed in a big way in European countries, a lot more than the United States. I mean, we have got Shukri Emri here, I'm so pleased to see, and Abhinav Huma. This is a picture of Thomas Starzl and Professor Ott, and he's being presented. Jan will remember a one-year-old child who was the longest survivor at that time. So that's how it was. And really, Professor Ott's review over a period of time has shown how dramatically, really, there has been an improvement in survival in the era, with the last era showing more than 90% survival long-term, 10 years for pediatric liver transplantation. Children do better than adults. Children do better than adults because their diseases are cured after transplant. Biliary atresia, which is the most common, there is no risk of recurrence in the majority other than maybe hepatoblastoma, which is in complete contrast to the adult indications where there is a high risk, at least in the hepatitis C era. Alcohol, which is the most common etiology, and fatty liver disease, all of them can come back after transplant. They don't have to have a normal liver function test in the long term, whereas in children, they do much better than adults. The first attempt, I mean, my talk is on living donor liver transplantation, and I'm going to show that living donor liver transplantation isn't a new technique for the pediatric liver transplant surgeons. The techniques involved have been the same, which is why I say. And the first ever attempt was in Brazil, really, which was, I don't know if you know the story, an airline pilot. It was advertised that a child needed a transplant, and an airline pilot got off the aircraft and got into the hospital and donated his left lateral segment. That was the first ever attempt, and you will see that the first successful one was done by Russell Strong in Australia, and it's also noteworthy to know that Russell Strong turned completely against living donor liver transplantation. If there is anybody talking against living donor, he's the first one to do living donor liver transplantation. So we need to take note of these points. And really, the pediatric living donor liver transplantation was done systematically by two groups, almost at the same time in Kyoto, Professor Tanaka. In the early days, before we started going to Korea, to Asan, it was actually people going to Kyoto to watch Professor Tanaka do living donor liver transplantation. And this is in 1991, if you remember. This is almost 28 years ago. The start of pediatric living donor liver transplantation came about. And we cannot forget the work done in Chicago. It was in the West that Professor Christoph Broelsch did the 20 cases. And you will see, I mean, if you look at, it's very interesting if you want to go back. In fact, they have identical outcome. There were 3 deaths among the first 20 in the Kyoto group, and there were 3 deaths in the first 20 in the Chicago group in the pediatric living donor liver transplantation. And that, this is again 28 years ago, which 30 years ago, they produced outstanding results that we can't match even today. So we have had many pioneers, and the first right lobe again was done in a child by the Kyoto group. And if you look at the first adult right lobe living donor liver transplantation, that was almost 10 years later or 8 years later. So this is the history, really. The techniques of pediatric transplantation started much, much more earlier than the adult, and the techniques we follow today is probably the same as we did in the adult. So I come from King's College Hospital, 1991, I joined there. I worked for 25 years. I was involved in almost 4,000 liver transplants there. In the early days, Paolo's here, Nigel, myself, and Paolo did almost, with 2-3 people, we were doing 200 to 220 liver transplants continuously. And that's what, and King's is also very well known for pediatric liver transplantation. And the technique that we followed really came from the split work that we did, really, the left lateral segment. You've got Professor Broelsch's unit in Hamburg subsequently, and you have here many people really. Jan Leroux was Belgium really, which started the split work for children. You have Max Malago, I saw, Data Brewing. It was an exciting time for us, really, to develop the technique of split, which is what made additional organs available. And in order for split for children to be successful, we had to make the right lobe successful for the adults, because if you didn't make the right lobe successful for the adults, the organs wouldn't be available for the children to be transplanted. And we really started split as an additional organ for the children. And if you look at, this is one of our publications in the very early days. This is 1998 publication. We were actually able to show, the bottom one is mine, where we could show with the right lobe graft survival of 90% and a patient, graft survival of 88 and a patient survival of 90%. Unless you could show this, we were not able to allocate. The hepatologists wouldn't have agreed on us doing splits and use the right lobe for the adults, which is what made really organs available for the children, which made our program one of the largest programs for pediatric liver transplantation. The only one comparable result is hidden by that red line is really the in situ split had comparable. So you could see, you could not have a 50% survival and say that it's got equivalent survival, really. So the split went through a difficult time, but we were able to show at the end both adults and pediatrics would have equal number too. And all of the complications we talk about, really, the bile leaks, the caudate lobes have all been described in the very early stages, not necessarily from living donor liver transplantation, but by experience from split liver transplantation. I mean, there are issues, there are specific issues in children and pediatric liver transplantation, but I won't go into the details of it, but I will just go through how our thought processes worked and how we really modified the techniques in this field, and in order to really transplant very young children. Situs inverses, you all know, have got little modifications that you need to follow. One of the problems that we took on very early on, again, many European surgeons would have done this, is the large foci. We just heard about small foci. Large foci was the issue. And when I joined King's, we had many neonatal transplantations. These indications disappeared. I think at one time we had almost 35 children under 1 month of age for transplantation. So there was that real issue. And when I went there, we looked at, Paolo's name is there in this paper as well, when we looked at under 3 months of age, this is again 23 years ago, this publication, we almost had a 50% mortality. It was a touch and go. You put in a large-sized liver into these patients when you take out a liver like that, and you had a huge problem. I heard Data Brewing says he doesn't do much reduction. I will say, it may be true, but there are children who only weigh 2.5 kilograms and 3 kilograms, and you got to put in a 300 grams liver. It doesn't sit in the abdomen. This is a real patient. It doesn't actually sit in the abdomen. You have to do something about it. It's only then really, I mean, once it doesn't sit in the abdomen, you have a huge amount of problem. You've got leaks, abdominal leaks, the outflow doesn't settle because the liver doesn't actually sit in the bed. Your outflow becomes a problem. There is a portal insufficiency because children will not perfuse a liver with a GRWR of more than 5. There is a relative ischemia. That may be an advantage. The liver size will come down. And this is something we described. And once we started doing really, this was a non-anatomical, this is not a true monosegment. Once we started describing the monosegmental graft, we instantly got one patient died of hepatic artery thrombosis actually out of 6. The survival figure improved dramatically after improvement in this technique. And this is again like a non-anatomical pediatric. This was an 8-year-old pediatric donor into a single segment 3 segment. And that's how a 5-day-old child was really transplanted with a monosegment with 8-year-old donor organ. I mean, this is again a hemochromatosis where the family lost 2 children before, and we knew that this child might be born with hemochromatosis. We were quite ready. And that's the girl, 22 years later. You'll be surprised to know she's a law student. She never had one CT scan in her life. She never had a rejection episode. We don't even know how that liver looks inside her anatomically, but she's got completely normal liver function tests. She's barely on any immunosuppression, and she says there is absolutely no need for her to have any tests really done, having done so well for so many years. So really, we looked at non-anatomical reductions and anatomical reductions. I'll come to it. Even with these reductions, sometimes these livers you can close the abdominal cavity. Sometimes you won't be able to close the abdominal cavity. And here is what I'm saying. We saw a whole liver where we couldn't close abdominal cavity. You can have a liver like this, which is so thick, you can still not close the abdominal cavity. It's not possible for these livers. And we had Kasahara with us, who's now really preeminent in the field of pediatric liver transplantation. He is the committee chair for the pediatric committee. He was one of our fellows. He spent 2 years with us, and he had an interest in that. We all look very young at that time, getting old now. And he wanted to explore really to reduce the thickness of the graft, and we've had discussions. I mean, it's been very kind to put me as a senior author in the middle of all the Japanese surgeons there, but the work was actually done by him, even though the ideas and discussions were ours. But he came up with this. He said if the GRWR is less than 4, you have to have a reduction in the graft, which I don't generally agree, which is what Data said in a meeting that he doesn't agree. But he showed in a large number of patients that, I mean, maybe not, with a GRWR of greater than 4, he got a survival of 56% or something, which may not be acceptable for pediatric liver transplantation. But now he's gone on and said that when you do this, it has to be a monosegment, anatomical monosegments. Anatomical monosegments are much more difficult than to do reduction, really, lateral reduction and medial reduction. And now he's showing that if you didn't do an anatomical reduction, your survival is again poor, which really a little bit far-fetched. He's not here, so I shouldn't say too much. I think it is okay in most instances to close temporary abdominal closure like this. The liver has the ability to shrink very rapidly. In fact, within a week to 10 days, it can shrink very rapidly. And I think that is because of relative ischemia that happens, because if a liver is 5 times the size that the child needs, the child is not going to perfuse that liver adequately. You may have very high enzymes in the early postoperative period, but the liver will shrink very rapidly. And you can close the abdominal skin alone and then come back after 6 months or 1 year and close the muscles. And this is what is contrary. I mean, after going to India, we've done between 2010, over an 8-year period, 373 transplants with the GRWR of more than 4 in 72 children. Actual reduction of the graft was only done in 22 patients. Most of them had non-standard abdominal closure, so it was possible. And even with sometimes the GRWR less than 4, you may need to do a non-anatomical reduction and non-standard closure. Usually these children are non-cirrhotic or metabolic liver disease where the abdominal cavity is quite small. So it doesn't accommodate even GRWR of less than 4 in those. I think the only point I want to make for people doing pediatric living donor transplantation is portal vein problem is probably the most menace. I see that much more in children in India than I ever did in the UK. We've done almost 1,000 liver transplants in children in King's College Hospital. And that is probably because in India, children with biliary atresia presents very nutritionally very poor. Their veins are very small, their flows are very small. And if you get a very early portal vein thrombosis, you've got a mortality in this of almost 67% mortality. And as you know, in children, there is a hypoplastic portal vein. Biliary atresia still is probably the most common etiology, other than probably in the Middle East, where PFIC is probably more common. 45 to 50% of the patients requiring children, pediatric transplant are children. And a significant number, you see here, the size of the artery and the size of the portal vein are the same. And if the size of the portal vein is less than 3 millimeters, you've got a risk of early portal vein thrombosis. In these patients, I personally think more than, when you do the surgery for biliary atresia, they actually don't have a hypoplastic portal vein. They get a hypoplastic portal vein over a period of time because the livers become very stiff. And the portal flow does not increase in these children. And it remains their neonatal size. It just doesn't grow. And also it becomes thickened over a period of time. It's actually not born with hypoplastic portal vein. I don't know why we use that terminology. If you actually do very early transplants in biliary atresia, you may not get a hypoplastic portal vein. So you'll see that if it is less than 3 millimeters, you may have to do interposition graft. And there are other issues really, not just the size alone, because the graft itself is quite large. If you see the position of the portal vein in the child to the position of where the graft portal vein lies, and if you want to bring them together, this is particularly so in living donor liver transplantation, where you've got only the left lobe. Whereas in the split liver transplant, you can allocate the main portal vein to the child and have the right portal vein for the adult. So you can bridge the gap between the two, and the portal vein can lie very comfortably. Whereas in the living donor setting, it doesn't. So you need to have an interposition graft in order to really avoid. And many techniques have been described, and we favor a simple interposition graft to the junction of the SMB and portal vein to go through that. I've had an interest, and we've had an interest in King's for auxiliary liver transplant. I always say this is probably not if you look at the description of an operation, it's not been taken up by the rest of the world in a big way. I still don't understand why. We still offer children with acute liver failure in India auxiliary liver transplant because it removes immunosuppression. Particularly, children do much better than adults, and this is a publication from a long time ago, 2010, where almost 75% of these children come off immunosuppression. And that is very relevant in our part of the world, where children don't have to stay on immunosuppression. And really, I mean, there have been a lot of worries about, I don't know how many of you, I'm sure all of you know about auxiliary liver transplant for acute liver failure, where you get a regenerating nodule like that. So you keep part of the patient's own liver, and when the liver regenerates, you can stop immunosuppression. Sometimes you have to go and remove the graft, but in most instances, you don't have to remove the graft. But it's been a particular problem in children because of the space. Here you see an auxiliary graft on the left side, and the native liver on the right side, and they are really squeezing each other. This is one of the issues. Even the room to do the anastomosis is an issue. But we have described many technical modifications to make this operation simpler. We now do an extended left and just keep the right posterior graft in order to create the space, because you know when you implant a left lateral segment, there is a space on the right side. So you just leave enough liver on the right side. It doesn't matter because extended hepatectomies have been done in adults with full regeneration. Similarly, you do an extended hepatectomy, and you can place a large left lateral segment of an adult into these. So many of these technical issues have been overcome, and here you see the example of such a large, the same patient, such a large left lateral segment graft. Over a period of time, slowly with native liver regeneration, withdrawal of immunosuppression, the left-sided graft is completely atrophied and disappeared. So everything is applicable. Again, with metabolic liver disease, we've been very keen on this. Part of the reason is because when gene therapy comes up, I mean, gene therapy is still not there. We do believe that gene therapy will be there. We'll all probably be dead and gone, but these children will be alive for the next 20 years, 30 years. So I always believe that we need to continue to provide these operations for these children. We did this for Crigler-Najjar syndrome. It's extremely effective for Crigler-Najjar syndrome. It disappears. These patients seem to get much lesser of an operation when you do auxiliary because they have their own liver. You're only replacing the left lateral segment in these patients. And rejection and everything really doesn't make them unwell. We've had many long-term follow-up for other conditions as well, like propionic acidemia, and the children seem to do well. It's all about understanding really portal steel and really we measure the pressure and flow in order to divert flow into the graft rather than into the native liver. You can see there is a band across the right lobe. This is not necessary in acute liver failure. It's only necessary in metabolic liver disease because they have a non-cirrhotic liver. I think if people understand, again, the way we do it and how, in a systematic manner how we do it is all published for you to read. One other problem for auxiliary in children was that the left hepatic artery of the child is very small. And we have to connect it to the graft artery because the graft artery usually matches. In most liver transplants, you match the left hepatic artery of the graft to the main hepatic artery of the child, which matches well. But if the left hepatic artery of the child is very small compared to the graft hepatic artery, so the incidence of hepatic artery thrombosis can be very high. So we devised this technique where we actually ligated the main hepatic artery trunk and did the anastomosis to the celiac. And the right lobe got its collaterals through the gastroduodenal arcade. So technically, it became really not a challenge anymore. So there are many small improvements in these techniques which have made it possible. And finally, really, when transplantation asked us to write a review in order to really promote a poll for metabolic liver disease, we had this opportunity where we swapped 2 livers from 2 metabolic conditions in 2 patients. One child with Crigler-Najjar syndrome, another child with propionic acidemia. So we took the left lobe of the propionic acidemia and gave it to Crigler-Najjar and the Crigler-Najjar to propionic acidemia. Single enzyme defect, and both metabolic abnormalities were cancelled by the other liver. And here we have transplantation without any donor, no cadaver donor, no living donor. So I've been fortunate. I moved to India in 2009. We've had a good program doing about 200 liver transplants a year. We have a large pediatric experience. I think we are the only center in India. We have 20 to 30% of our program is cadaver liver transplant. We've done close to 500 cadaver liver transplants, kept our interest in pediatric liver transplant. Our program does about 60, 65 pediatric liver transplantation as well. And our results have been very good. It's not been any different from that in King's. I moved to a new center, which is a 450-bedded hospital. It's a multi-specialty center, but we specialize in all sorts of transplantation. And what I'm fortunate about is my team moved with me. 270 people moved with me from the previous hospital to new hospital, which resulted in a little bit of an upset for the old hospital, and it was a bit of a trouble for me. Over a 10-month period, we have done 234 transplants in the new center, so the numbers didn't drop. And we've done well, and I'm happy to be back in India. I'm back in my hometown to serve the population. And really, this is 1 month gap between children after transplant. We've been fortunate that the government funds transplantation in our state in India, so we are able to do free transplants for children. And also there are many NGOs now in India. So almost 20 to 30 children in our program get a free transplant in our program. So that's been a huge benefit for us. And I think last month we did the youngest child, which is a child with a 1-month-old child to have a liver transplant. So everything is possible. I think you can translate all the work into our part of the world as well and offer a good service. We also have a meeting. Many of you have come there, Masterclass in Liver Disease. This is a teaching meeting that we have in January. It's in the end of February 28th to March 1st, and I would invite you and come and visit our new program, the new hospital, as well as come to the meeting. Thank you very much.
Thank you very much, Professor Rela, for this amazing presentation and talk. Actually, we have time for a few questions and comments. We can take a few questions from the floor.
That's okay.
Then I have a question and a comment. when you have a graft, a long graft for a pediatric patients, I mean when the distance between hepatic vein and portal vein is longer than in the graft is longer than it's in the child. What would you suggest to do?
I mean, I saw the picture. See, an adult liver is large.
Yeah.
The child's liver is small. The length of the child is small.
Yeah.
Compared to the adult. So if you take a child's liver out, if you look at the distance between the portal vein to the hepatic vein, it has to be much shorter than a long adult.
Yeah.
So you put a long adult's liver into a small child.
Yeah, that's right.
The distance is not going to be the same. So if you force it to bring it together, most often you can bring it together, but if you force it to bring it together, you will kink.
Yeah.
And if the flow is not good, I think it's always better to put an interposition graft when there is a very large for size.
Okay, thank you. Yeah.
Yeah, Mohammed, amazing. Yeah, congratulations. This is really constant work over so many years, and you deserve really this success.
No, well, today I thought I met so many of you. We are all doing this at the same time in Europe. That's why I feel so good about today that there are so many of you in this meeting. I think this is quite a high-profile people in this meeting.
My question is regarding biliary complications, which is still the Achilles heel of segmental liver transplantation. And I'm sure that your biliary complications in the pediatric population, so left lateral, is much less than in the adult.
Very low, much lower than adult.
And why? So we are still, since 20 years, we cannot answer this question, why we have this very, very low biliary complication rate in maybe smaller bile ducts in the left lateral lobe, compared to the bigger bile ducts we are seeing now here. This bile ducts will be soon anastomosed. Why they are
you can say
still higher?
There are many reasons, really. See, the left hepatic artery, the retrograde flow may be better on the left side because it's the left, where the transection point of the left hepatic artery is far for it to reach it from the arterial supply of the gastroduodenal running along the left side. Maybe the left artery is reaching retrogradely that side. Whereas on the right side, it has to grow mainly from the retrograde flow and you're dividing it. Maybe the supply is not as good. I don't know. The second thing is, I think the Roux-en-Y hepaticojejunostomy and getting vascularity from the bowel into the bile duct is probably also better in the long term to prevent strictures in the long term. There are many little things actually. The biliary complication rate is much lower in children compared to adults. I think hepaticojejunostomy is one of the answers. And the other is really the arterial supply which comes to the point of division of the right duct may be coming from the lower side rather than the retrograde side compared to the left artery at the site of division, which is far away from the hilum, may be coming from the left side retrogradely.
Well, any more comments or questions? I just have one comment. When I used to do pediatric transplants at UCLA, we always used to think about what's the smallest child you've ever done. So I'm going to ask you that question. What is the smallest child you've ever done?
2.4 kilograms.
Okay, very nice. Thank you very much. And looking at the children when they grow up, it's amazing. Thank you. 2.1. Okay. 2.12. Did I stir something?